In 2007, I had a left breast mastectomy. This came after many hard decisions had to be made because my oncologist went on a leave of absence and the replacement oncologist did not want to do a mastectomy at all, and she wanted me to have a course of chemo. It was a rough time to know what was best for me. Hi, I'm Denise and welcome to Travels in My Chair. Today we're going to talk about boobs. When you're first diagnosed with breast cancer, you're going to be asked to make some pretty difficult decisions, some choices that you probably never thought you'd have to make, or you don't necessarily want to even make, but you have to. And those decisions are, of course, working with your specific treatment that works best for you. My oncologist wanted me to have a mastectomy. My tumors were too spread out, and one was near the nipple and areola, and she felt that in my case a mastectomy was the only way to go, and that I couldn't have a lumpectomy because the tumors were too large. I just want to remind you right from the onset that I am not a doctor. I'm not medically trained. I'm merely a cancer patient who's dealing with a lot of these things and has a lot of the same questions that you probably have with your cancer journey. So just keep that in mind, okay? Always deal with your medical profession. I mean, they've gone to school for a long time to get to where they are, right? Depending on the type of breast cancer you have, you may have to have chemotherapy before you can have the mastectomy. So each person is different, always. For example, if you have inflammatory breast cancer and you're maybe a bit younger, it may be determined that you should have breast reconstruction surgery and try to preserve your nipple and areola area of your breast so that it looks more realistic. With inflammatory breast cancer, that could be very rapid growing. It may not work to do implant surgery that takes place at the time of your mastectomy because the area around your nipple and areola may, when you end up having radiation, may end up shrinking that tissue, and then you're in for a nightmare. So the least complicated reconstruction surgery is where, and this is one that 90% of women use that are going to have the reconstruction surgery. It's where you have your mastectomy, then there's an expander implanted, and your tissue is slowly expanded, or your skin, and then a prosthetic breast will be inserted. That seems to be the one that most women choose to have. But it may surprise you to know in this day and age that only about 50% of the women that have breast cancer choose to have reconstruction surgery at all. Lots of conversations with my very excellent surgeon. I asked her if I could have bilateral surgery and have both breasts removed because I had a customer at work that had to have bilateral surgery, and she would wear loose-fitting t-shirts and clothing, and you could never tell she didn't have breasts. And I thought, well, there's something kind of nice about that, not to have to worry about a bra. I'm not 30 anymore. The other thing would be, I think if you were a large-breasted woman, you may choose to have reduction surgery on your remaining breast to put them in balance and sort of make it a little bit easier for you. Either way, I have small breasts. It was something that, in the end, after I've been dealing with being teased about my small breasts my whole life, it was a fairly easy decision to make, to just have the one removed. My surgeon connected me with plastic surgeon reconstruction specialist. There was a lot of discussion, me mostly with my surgeon, as to what my body would have to go through to have reconstruction surgery, and if that's what I really wanted to do. And I was unsure. First of all, when you have breast cancer surgery, you have drains put in, and those drains usually stay in for a couple of weeks. At first, they're running quite red with blood, then they go pinkish, and then at the end, yellowish. Well, my drains were in for 6 weeks, and they always stayed either red or pink. They never did go yellow. That was one of the reasons why in the end we decided not to go with reconstruction surgery, because for me it was the fact that I was still walking with a walker with my MS. So I was putting all my weight on the handlebars of the walker, and that was stopping this area healing properly. And my surgeon felt that if I was to have implant surgery, that could be a real issue for the healing process, because she had to take some lymph nodes out, 12 lymph nodes out from under my arm, and 8 were compromised. So in the end, I had to have radiation all in there and all in my chest wall. Now, as a matter of interest, at the time that I was having my surgery, Princess Margaret, I think is the name, hospital in Toronto, was the one and only hospital in Canada that had a new procedure out, and it was when you had your mastectomy and you were still open on the table, they came in with a special radiation machine and did a heavy dose of radiation in your chest wall. Then you could have your reconstruction surgery at that time if you wanted, or start it, depending on which reconstruction surgery you were getting. Changes have been made, obviously, in the breast cancer world since 2007, and I'm sure they're changing every day. Right after the surgery was done, I was laying in bed and I kind of looked down my shirt and saw the scar. I thought it would affect me more than it did. It didn't affect me. I just kind of looked at it and went, you know, you guys were never anything but a problem my whole life. Now, the other kind of reconstruction surgery is one that isn't used as often, but more and more women are deciding to have this kind. It's where they start the reconstruction when they've done the mastectomy while you're still in your surgery. So they take usually skin and fat from your belly, because that's usually where we poor women have most of our skin and fat, and they use that to start the reconstruction surgery. This is called dip flap surgery, and it's a more complex surgery. A soft implant is inserted at the time of surgery, and then that is working with the skin that they've taken from your belly, just stretch. And again, you know, I had wanted my surgeon to actually take off both breasts because they were small anyway, but she wouldn't do it. She said, you know, you're going through so much discomfort having to use the walker and so much pressure on your arms and shoulders with your MS that I think it would be a hindrance to you to have to try and maneuver stuff with the MS, trying to not use the arm to support all your weight because it wouldn't allow you to heal properly. And doing it on 2 breasts when it's not necessary, I just don't think it's worth the problems that it's going to cause you. And really, you know, I had the surgery in July of 2007, and they didn't start the radiation till October, the middle of October. And during that time, we were wrestling with my drains, making sure I wasn't getting infected. I wasn't allowed to wear a bra. I had to try to go back to work wearing a loose-fitting top. And, you know, it was a real pain. In retrospect, if I was having the same surgery tomorrow, I think I'd probably have gone anyway with the double mastectomy, because in the long run, I'm always trying to find a bra that's going to fit me properly with a prosthesis in, and my boobs are kind of crooked because, no, this way, because my right side now is bigger, and as I'm older, it's droopy, and the left side, of course, is pert with whatever. And so I can never get them even, no matter what I do, and that's either way, no matter what. My boobs have been a pain in the butt since I was 14. It still is a pain in the butt. So remember, if you are getting reconstruction surgery and you have to have radiation, that's something you need to talk to your surgeon about, to talk about when is the time to start the reconstruction surgery, what type of reconstruction surgery works best for you and your case, and also take into consideration the size of your breasts before the surgery, because if you are a very large-breasted woman, you may opt for, at the time of surgery, to see if they will do a breast reduction on the other breast. And then when they do the reconstruction surgery, you know, it would look probably better, probably be easier on you. But again, that is your decision, right? So remember, reconstruction, they start inflating, put in a soft tissue prosthetic at first, end up with proper device after. The other one is they start it right at the time of the surgery and take the skin from probably your belly or some other fatty area and start then. So the decision for you to make is A, do you want reconstruction surgery? B, of the other two kind, what kind do you want that's going to work best for you? And have an honest and open conversation with your surgeon. If you do decide on reconstruction surgery, then talk with the breast reconstruction specialist, plastic surgeon, because they do lots and they probably have some really good ideas. And they will work in tandem with your surgeon as a team to get you the best outcome that's going to work for you. Whatever you decide to do, it's really important to treat the cancer first. That is your job. The rest is all superficial, isn't it? We want to look good, but only if we're alive. So treat the cancer first. Talk to your oncologist, talk to your surgeon. Decide what you want to do as far as reconstruction surgery, or if you even want to bother. And you know what? If you decide not to, don't feel guilty about it. Hey, it's your body. You're more than just your breast. Thanks for watching, and we'll see you in a couple of weeks. Bye for now.